Professor Beebe, and I just wanted to go through a summary of chapter one to kind of help you with the content before we get ready for our midterm. So this first chapter is really just an introduction to the concept or the field of epidemiology. So these are the objectives for this chapter. I'm going to go through each one now, so I'm not going to read this list, but you do have this if you'd like to use it to make a study guide uh, to help you study. So when we talk about health, there's a lot more that goes into health than just blood test results you get back or heights and weights. Health is more of a holistic view, so we aren't just looking at physiological health but we also are looking at mental health, social well-being. Uh, there's a lot that we are going to take to kind of give us this whole picture of health. Do you have access to health care? Do you live in a safe environment? Is the environment that you live in dangerous? Is it might be a war zone? There might be some violence. There might be conflict. You might live in an area that's a food desert, so you don't have access to healthy foods at a reasonable price. So these are all things that go into your overall health. So it's really not just the absence of disease. And public health is when we are looking at health on a population level. So it's more big picture. We're looking at how does the population look from a health standpoint. So we're usually looking at a curve, where we have the center of our population, of our target population, and then we have the outliers. So we might have the extremely healthy on this side and the ones that are suffering from more poor health on this side. So for public health, we're looking for trends. And we're also looking on how can we move this curve? So how can we move this curve to make the entire population overall more healthy? We're not focusing on just one individual. And this is what I've been talking about, the social aspect of health. Are they creating social relationships for support? What do those look like? Are these social relationships that are maybe a negative influence on health? Maybe there's a society that downgrades the importance or the well-being of females or certain marginalized populations. So what's socially going on? Economically, are we looking at an area or a target population that is low socioeconomic status? Family, what type of family structure are we looking at? Okay, are we looking at high levels of marriage? Are we looking at marriage, maybe marriage and divorce rates? Okay, so those are areas that we're looking at. Are they able to get a job? Are they able to support themselves? And then geographically, once again, are they in an area that is subject to a lot of natural disasters like hurricanes that come through, those types of things. So there's a lot that has to do. And geographic factors, we can also look at urban versus rural. So when we look at kind of this relationship between public health and epidemiology, we are looking at kind of looking for trends, looking for observable characteristics. Sometimes these might be risk factors. And we're collecting data and we're going to analyze that data and decide what we can do with it. Okay, so perhaps we're collecting data that shows that rural residents in our area have less access to healthcare, or rural individuals in our area have don't have the same level of sanitation or fresh water or potable water that they might have in a rural or an urban area. So those are the types of things that we're looking at. And then what are we going to do with that information? You know, once we collect that information, once we interpret it, how can we use that to create a better health outcome for those individuals? Okay. Frequently, we'll use that by creating health promotion events. Um, Maybe that's to prevent disease. So maybe we will create a program that allows for testing of wells or testing of water sources to make certain that the water sources are clean. But how are we going to use that information? So epidemiology can really be thought of as the foundation or the source of public health. So in epidemiology, like I said before, we're looking at the distribution uh, and determination of health-related states or events in human populations. Okay, so we're collecting data, we're finding out what's the prevalence or what's the incidence of certain diseases or disorders. That allows us to prioritize public health. It allows us to prioritize what should we be focusing on? Where can we make the biggest difference? So many of you are probably very familiar with the scientific approach, the whole idea of making an observation, looking at that observation and hypothesizing, why do we think we're seeing what we're seeing? Okay. And then once we make that hypothesis, setting up experiments to test that. Okay. And then we're going to go into more detail of the epidemiologic study plan in chapter 4. Okay. So when I talk about distribution, what am I talking about? Well, I'm talking about frequency and pattern. What's the number? What are the numbers of these health states or events that I'm looking at? And how are they being distributed? Okay, are they more likely to occur in a certain marginalized population, a certain area, a certain region? So that's what we're looking at, frequency and pattern. And that pattern can be thought of who, so which groups are being affected. Maybe it's based on gender, maybe it's based on age, where, okay, what place are these individuals that are living in rural areas, in urban areas, in coastal areas? When is this happening? Okay, so how frequently or in are we looking at something that's endemic, pandemic? What are we looking at? And then, of course, what is the clinical criteria? How do we define this health state or event? So when we looked at our recent COVID death rates in the United States, you can see here that if we start looking at it and start taking it apart by different groups, even gender, we saw a large difference in the numbers of females versus males as far as the COVID-19 death rate. Okay, so we are seeing a differential in those two populations. And then we also saw a differential in the age, okay? Individuals that were greater than 85 had a much greater likelihood of dying with COVID than those that were less than 40 years of age, okay? So these are some of the insights that we can get from the data that we collect as part of epidemiology. And what that can do is that can actually lead us to creating health promotion events for those that are most at risk. So the determinants are the factors that produce a health outcome. Okay. There is an emphasis on causality because in epidemiology, it's very critical for us to be able to propose effective prevention. We need to know what causes it. Okay, so we have to look at all the evidence that we've collected. So if we look back here, all this evidence that we collected about the death rates from COVID, we have to take that information and start identifying some of these associations, these causal associations, and use that judgment to drive our efforts. So health-related states or events are basically diseases that we can talk about, pneumonia, mental illness, the flu. It can also be referring to conditions associated with health, okay, such as seatbelt use, nutrition, if we're talking about wasting, and then also events, injuries. So injuries is one that we look a lot at for global health. We look at road injuries are a very high incident cause of injury. And then prevention. So prevention is the idea of we're trying to avoid the occurrence of disease. And there's different levels of prevention. There's primary prevention, in which we are trying to prevent the disease from even happening. Okay, so these might be efforts in which we have a seatbelt campaign. So before the person passes away or before a tragic car accident, we try to get people to wear their seatbelts. So we have a seatbelt campaign, or mammography campaign for breast cancer. Okay, that's primary prevention. Secondary prevention is aimed at catching the disease early. Okay, so these are our screenings. So this is our attempt to catch these diseases earlier, because we have a better chance of defeating them, a less chance of long-acting disorders if we can catch it early. Okay, and then tertiary prevention is if we're looking at individuals that already have the disorder or disease, and we are trying to make the outcome or the treatment better for those individuals. So we have these three different levels of prevention. And then control is how we try to prevent the further spreading of disease. So when we were in the COVID, when we had the COVID pandemic, we were trying to control the spread with masks. We were trying to control the spread with vaccinations, okay? We were trying to control it from getting any larger or any bigger. A risk factor is something that increases your likelihood of developing the health outcome, okay? So with the COVID pandemic, some of the risk factors were traveling into large groups. Some of the risk factors were not getting the vaccine. Some of the risk factors were not wearing the face mask. These were all factors that increased your likelihood of coming down with COVID. Okay, so when we talk about modifiable risk factors or non-modifiable risk factors, modifiable risk factors are the ones that we can make the decision. So we can wear the mask, we can get the vaccine, versus non-modifiable ones that might be genetic. Okay, and frequently we're also looking at, is a single risk factor sufficient to cause the disease? And in most cases, no, because we are looking at numerous risk factors that combine together to create that instance. Epidemic, endemic, and pandemic, these are words that you are probably very familiar with since 2020. Epidemic is defined as a population above the expected level over a given period. Endemic means that it's persistent. So this is usual in our population over a given period. And then pandemic is an epidemic that's actually spread beyond that local region or local area. And then an outbreak is an epidemic that is geographically and time constrained. So we have different types of epidemics. We have common source, propagated, and mixed epidemics. So common source is one that is from a single point of cause, okay? This might be intermittent, meaning it might be something that varies with seasons, or it might be continuous. Propagated is an epidemic that is spread from person to person. And then a mixed epidemic is a combination of the two. So if we have a common source, such as when we were in the COVID epidemic. So when we have a common source, and then out from that source, it becomes highly contagious like it did, and then it became propagated. It was traveling across the globe from person to person. So we ended up with a mixed epidemic. So once again, a common source is when we have a disorder, a health-related event that's occurring more rapidly from that common source that we're talking about. Examples of this are often food contamination, such as anthrax, botulism, or something that we're looking at, like with cholera, where we have the contamination of the Vibrio cholera bacteria within the food and water. Propagated is one that travels or is easily transmitted from one infected individual to the other. Frequently, these are ones that are transferred via respiratory droplets, via coughing, sneezing, such as the ones that we're seeing here. TB, whooping cough, influenza. And then mixed epidemics are ones, like I said, that can start off as a common source and then will be spread person to person. So here I list the example of Shigella. So one thing that's really important, and this was very evident during the COVID pandemic, was we need a very good, tight definition of whatever health event or disorder that we're talking about. Okay, so frequently we see what's called a case study. And a case study is when someone presents at a physician or a doctor with a unique set of symptoms, signs and symptoms, and starts to define this new case or this new health disorder. All right. But if we don't have a well-defined disorder, we don't know how to count people. All right. We need to be able to put them into our count. And so we need a tight definition so that we can know for certain that this individual belongs in this count. Okay. If our data is not sound, if we have a loose definition, and our data is not sound, then our epidemiological data doesn't really help us moving forward. So a case is a person who has been diagnosed as having whatever disease or disorder or injury or condition that we're talking about. The primary case, or also called an index case, is the first disease case in the population. All right, so this is the first one that has been brought to attention. Okay. The secondary case are those who have become infected and ill after the disease has been introduced to a population. And then, of course, we have different levels of diagnoses. So we have a suspect and a confirmed level of diagnoses. A suspect is one who is exhibiting all the signs and symptoms of the disease and condition, but have yet to be diagnosed. One that's confirmed is a person or an individual where all the criteria have been met. So all that criteria from that definition that we've been talking about have been met. And so this individual is now confirmed for that disorder. So how are these diseases being transmitted? So direct is person-to-person contact, okay? So this is an exchange of body fluids. These are disorders such as STDs, sexually transmitted diseases, that require person-to-person direct contact. And then we also have fomites, vehicles, and vectors that we're going to talk about, okay? So a fomite is a non-animate object. So it's something that's not live. So these are objects such as doorknobs, clothing, towels, that can harbor a disease agent and capable of transmitting it. Okay, so One thing that has to be kept in mind is many different bacteria or viruses have different amount of time that they can stay viable on a fomite. So some might be more hardy and can remain viable on a doorknob or viable on a utensil for much longer than another one. A vector is an invertebrate animal. Okay, so this is a tick, a mosquito, that are capable of transmitting an infectious agent among vertebrates. Okay, so they can spread that agent from one infected animal to another. They can carry that, they can deposit it through their waste products, their body fluids, okay? Or they can actually deposit it on food that we then consume, okay? But I just want to point out one thing again, the difference here is vector is a living organism versus a fomite, which is not, is inanimate. A good example is Yersinia pestis. That is the bacterium that causes plague. It's found in rats in certain parts of the world. You might have seen out in the Midwest, there was a recent infection of plague. And usually what happens is the Yersinia pestis is transmittable in one of three ways. So it can be from the bites from infected rodent fleas. So a flea will bite the rat that's infected. It can be direct contact with infected tissue or bodily fluids, or the inhalation of infected droplets. Reservoir is a living or non-living habitat in which an infectious agent can live, grow, or multiply. Okay, these infectious agents are dependent upon these reservoirs to survive because bacterium or infectious agents rely on being able to reproduce and create large numbers to create an infection. Humans can often serve as both reservoir and host. A zoonosis is a disease that is transmitted from an animal to a human. So a good example of this is rabies. Rocky Mountain spotted fever is another one, but these are animal diseases that are transmitted to humans. A carrier is someone who carries a certain infectious agent, okay? So they might not be showing symptoms, signs or symptoms of the diseases, but they can still be carrying it, okay? So during the COVID epidemic, that was something that was being talked about a lot, was the whole idea of someone being a carrier for COVID. Not having symptoms, not having signs, and actually unknowingly transmitting that disorder to other individuals. So when we talk about that transmission, we can talk about direct or indirect. Direct, once again, when I talked a little bit before about sexually transmitted diseases. These are ones that require direct physical contact. Okay, so this might be contaminated hands, might be skin to skin contact, kissing, okay, versus indirect transmission, in which we're looking at someone that can, or something that can be transmitted as an airborne infection, such as sneezing, coughing, or something that's going to be carried by a vector, so something like African sleeping sickness carried by the tsetse fly, or something that's vehicle borne. So what is this chain of infection? Okay, so once the pathogen, once again, whether it is a bacterium, leaves its reservoir, it's going to follow whatever mode of transmission it takes to a host. And once again, this could be direct transmission, this could be indirect, via sneezing, coughing, excuse me, vectors, fomites, food. And then the final link of the chain is the susceptible individual. And the reason I say susceptible individual is because certain bacterium, certain viruses are only viable in certain species. Okay, so we need to have a susceptible host to actually close that chain of infection. Right. So if it's something that is only susceptible to dogs, let's say, a virus that's only susceptible to dogs, if this susceptible host is not a dog, then we don't complete this infectious chain. Okay. Um, these are the three levels of prevention that I had talked about earlier. Remember, primary prevention is prior to exposure. So these events are where we're trying to prevent the disease or disorder or health event from even happening. So these are immunization, education, warning labels, just to prevent it from even happening in the first place. Okay. These are some examples, once again, that I've already mentioned earlier in this presentation. And then we also have passive primary prevention. Okay, so active is something that you actively do. So you actively take part in health education. Okay, you actively put on sunscreen to prevent skin cancer. Passive is something that you don't have to have a behavioral change for. So this is the fluoridation in our public water. Okay, that's not something that requires you to have a behavioral change. It's in there. Vitamin fortified foods, another, it's in there. The iodine in the salt is a great example of that. It's in there. It's not something that you have to actively have a behavioral change to reap the benefits of that. Secondary prevention is the one that I mentioned that allows us to catch the disease early on. Okay. And by catching it early on, we're hoping to reduce the progress of the disease. So these are our mammograms, so we can find them early on. Okay. These are certain blood tests, certain exams that the doctor gives you to catch anything that's off within your health. And then tertiary prevention is the one that helps us limit the disability from disease. Okay, so whether it's us getting medications that reduce the nausea from chemotherapy, if it's something that takes away some of the symptoms, sign or symptoms of the disease, but to get rid of or to limit some of the disability that's caused by it. So we talked a little bit about this already, but this is just a few more details. Okay, we talked about that relationship between epidemiology and public health. The idea that epidemiology is the foundation of public health, and it is because once again we have this great amount of data that we're collecting from epidemiology. And this allows us to have assessment. It allows us to assess the health of our population. So we can figure out how to prioritize health problems. We can figure out what certain population we might need to prioritize. We can figure out when is the best time to roll out these health promotion events. Okay. And then we can follow and monitor changes over time. We can follow and monitor these populations and maybe identify more risk factors. Okay. Um, we can also, it helps with causality. Okay. It can tell us what do these affected individuals have in common? What in their past, what risk were they exposed to, brought them to this health outcome? It can help us identify the mode of transmission. All right. So all of these are ways that epidemiology support and form that foundation of public health. It gives us a full clinical picture. It tells us who, it tells us why, Okay. It tells us what we can expect to happen or what we can expect to see from this disease. It can tell us how can we identify individuals that might be subclinical. So they have been exposed to the disease, but they're not yet showing visible signs of the disease or disorder. How long will that subclinical phase last? Because that's very important. Telling us how to treat or to take care of this disease or disorder. Oh, Duncan, Duncan. Get away. Get. Okay, sorry about that. Let me get back to where we were. Okay. Once again, I apologize for that. Um, and then, of course, evaluation. Evaluation is really important. When we design these health prevention events, we need to make certain that they work. So we can't just roll out a program for seatbelt safety and never go back to see if it even was effective. So that's a very important part of epidemiology. Public health surveillance is something that everyone became very familiar with during the COVID pandemic. Uh, we had that dashboard that you saw in the news all the time that followed the numbers by state, letting us know how many cases of COVID were in each state and where the growth was the greatest. So this public health surveillance is very important because it allows the public health and health communities to stay on top of diseases or disorders that are highly transmissible. So if we have an outbreak, we can get out ahead of it. So when we look at health promotion programs, we look at efficacy and effectiveness. Okay. And to do that, we have to look at the clinical characteristics of the disease. And once again, that goes back to the whole idea of having a well-defined disorder. Um, we have to look at the natural history of disease. What does that bacterium need to survive, to multiply, and to cause health disorders in individuals? Okay. We need to look at those risk factors because then we know what we have to work against, if you will, to prevent that health outcome. Okay. And then, of course, we have to look at efficacy. All right. Was it efficient? Was it an efficient way to prevent this health issue or disorder? Okay. And then how well did it do? Okay. What was our return on investment for this intervention? Okay. And then these are just list of applied oriented epidemiology jobs. Um, well, not the jobs themselves, um, but aspects of those jobs that you can read through. Okay. Questions that need epidemiology, once again, diagnoses, okay, causes, treatment, prognosis. And then these last two slides are summaries of the chapter. I hope this was helpful to you, and please let me know if you have any questions. Thank you.